Hello, this is Mrs. Condry. This is postoperative care for NUR 1213. Our objectives is that you will identify key assessments and interventions for the postoperative period, explain the rationale for these interventions, and we will summarize the effects of surgery on the pediatric and elderly client. So the post-anesthesia care unit is a very important step in the patient going to the OR. There's a transition of care of the client where they go from the OR to PACU, and the OR nurse gives a face-to-face report to the PACU nurse. Both nurses should view that operative site. This also occurs in a post-moderate sedation, such as the Cath lab. So we have the Cath lab nurse comes to recovery and gives a face-to-face report, and together we look at the groin or we look at the wrist depending on what the access site is. That's a very important step, because the last thing you want to do is to take over care and the next second the patient has bled out. The PACU nurse does the initial assessment of airway, breathing, circulation, neuro, GI, GU, surgical site, and pain, and we're going to discuss each of those in depth. So the respiratory complications can include obstruction, hypoxemia, and hypoventilation. Airway obstruction is often caused by the tongue, because when people are asleep, their tongue falls back and obstructs, so they can't breathe properly. Hypoxemia is the PaO2 below 60, and it's often caused by atelectasis, and remember that's where your alveoli deflate. And it can also be caused by pulmonary edema, and that's edema in those pulmonary arteries and veins. Pulmonary embolism, where there are blood clots in the lungs, and bronchospasm, of course, you know, and hypoventilation, so they're not breathing deep enough or enough per minute. On the unit, on your clinical unit, respiratory problems are usually from atelectasis, which can lead to pneumonia. So as a nurse, we're going to, of course, assess the lungs. We can elevate the head of the bed, which helps them get more oxygen and breathe better. We want to give oxygen if the oxygen level is usually below 95%, but if it's a patient with COPD, it's usually between 88 and 92. We're going to encourage the patient to turn, cough, and deep breathe, TCDB. You'll see that abbreviation that I used later on in the PowerPoint. And we're going to encourage this incentive spirometer. So the patient will put this right here in their mouth. They're going to blow out first, so they don't put this in the mouth until after they blow out, and then they put this in their mouth and they're going to inhale, and this ball will move up. And so someone with really good lungs like me might get up to 2,500. Somebody with less lung capacity might only get up to 500. But that will help open up those alveoli that have collapsed, because general anesthesia in the ventilator is not does not allow all the alveoli to stay open, not like us taking breaths. And then we're going to encourage hydration. There are cardiovascular problems that can occur. In PACU, you may see hypotension, we might see hypertension, and we might see dysrhythmias. So usually hypotension is from unreplaced blood and fluid loss. So someone might lose a couple liters of blood. If that's not replaced, they can get hypotensive. Hypertension can be from pain, or I'm really anxious, or my bladder is really full, or I could be hypothermic and I'd be shivering, and so my blood pressure might be elevated, or can have pre-existing hypertension. I might take 4 medications and I only took my beta blocker today. Well, then I might be hypertensive. And dysrhythmias can be from hypoxemia, so that's the oxygen level being low, hypercapnia, which is the CO2 levels increased, and that's because we're not breathing fast enough per minute. We might have alterations in our fluid and electrolytes. We might have alterations in our acid-base balance, or we could have pre-existing heart disease. So the patient has frequent PVCs, which is called premature ventricular contractions. So you might see that in PACU if they already have that. So in post-op, in the PACU, fluid and electrolyte imbalances are often contributing factors. And fluid retention can often occur from days 1 to 3 from our stress response. So this is a review of fluid and electrolytes, this stress response activates antidiuretic hormone and ACTH and the ROS system. So in my other soft chalk lesson, I have more information about those systems. ADH release increases our water reabsorption. So think antidiuretic, it's not allowing us to diurese. So we're increasing our water reabsorption, we're decreasing our urine output, and we're increasing blood volume. Our ACTH stimulates the release of cortisol, and fluid losses stimulate the ROS system, which increases our aldosterone and our sodium and fluid retention. So fluid overload can occur from IV fluids which are too rapidly infused, or the client can't handle the extra fluid, such as an elderly client or those with renal or heart failure. They can't handle that extra fluid. So you can have fluid retention or you can have fluid overload. And the fluid deficits can be from dehydration that was prior, because the patient had to be NPO and they say, oh, I never drink past 6 p.m. So they could be dehydrated, and the surgery might not have been till 12 or 2 o'clock in the afternoon the next day. That's a long time without anything to drink. They could have lost blood. They might not have had adequate fluid replacement. They could be vomiting, or they could have lots of suctioning. And that can cause decreased cardiac output and decreased tissue perfusion. So fluid deficits can cause that. Hypokalemia could be from GI or urine losses. And remember, potassium affects our muscles contraction, and our heart is a muscle. So hypokalemia can affect our contractility of our heart. So that could lead to dysrhythmias. The stress response, because the body is certainly going through stress with going into the OR, it can increase our clotting tendencies, and that can lead to an increase of risk of blood clots in our legs. Syncope can indicate decreased cardiac output. It can also indicate fluid deficit, and it can indicate decreased cerebral perfusion. So if our oxygen levels low, you don't have them being monitored, they get up, they feel faint, that can indicate one of those. It can also be common, postural hypotension can be common in the elderly and someone who's immobile. So if you're on the OR table for hours, you're a little bit dehydrated, you get up, you can feel faint. So in the Cath lab, in recovery, we do orthostatic vital signs with all our clients who've been in bed more than an hour, just to make sure that they're not going to pass out. In PACU, we're going to monitor their vital signs. It's sometimes every 5 minutes, sometimes every 15. We're going to compare those pre-op and post-op vital signs to make sure there's not this big alteration. We're going to monitor their ECG rhythm for those with cardiac disease and the elderly, and then your pediatric book also said the pediatric clients should also have an ECG monitor. We're going to treat hypotension with IV fluids and oxygen. And if that doesn't work, they may require vasoconstrictive drugs to increase their blood pressure. And if they're hypertensive or they have some dysrhythmias, we're going to treat that underlying cause. And if it's alteration in their potassium, or they have an acid-base balance problem, we need to treat that. But they may require antihypertensives, especially if they take antihypertensives on a regular basis. On the clinical unit, we're going to monitor the INOs, their labs. We're going to give IV therapy, and of course we're going to give IV fluids in the PACU as well. We're going to, of course, assess. Everything's assess. And we're going to encourage early ambulation, but we're going to prevent syncope by getting the client up slowly. So instead of just going straight from, especially the elderly, instead of going straight from laying down to getting up really quickly, we want to wait a couple minutes just sitting on the side of the bed before we get them up walking. The neurological and physiological problems we might see in the PACU, there's something called emergence delirium, where the client wakes up flailing. We want to suspect hypoxia first, so we would apply oxygen. Or sometimes they wake up and they take off their oxygen. We want to put the oxygen back on. It's common for kids to wake up wild, so it's really helpful to have a parent there in PACU to calm the child when they wake up like that. And there's also something called delayed emergence, where the client takes a long time to wake up. And when you ask someone in a pre-op interview if they've ever had any problems with the anesthesia, if they say, hey, it took me a long time to wake up, they may give less anesthesia this time so that that doesn't occur. On the clinical unit, it's common to see post-op cognitive dysfunction, where the client's memory is affected for weeks and weeks. And this is definitely more common in the elderly client, and it also can occur with heart bypasses because they're on the table so long. There can be delirium, which is a cognitive dysfunction where they have decreased level of consciousness, their sleep-wake cycles are all messed up. And this can be from severe pain, it can be from fluid and electrolyte imbalances, hypoxia. It could be from drugs that the patient received in the OR, and it's more common in the elderly. It takes the elderly a lot longer to process all these drugs. That my kidneys might work much quickly, or very quickly, to process something, or my liver might process something quickly, whereas an 80-year-old, it might take double that time. It also could be alcohol withdrawal delirium, and if someone says in the pre-op area, oh, I drink about six beers a day, it might be 12. It's probably underestimated, and so if they drink a 12-pack or a 24-pack in one day, it doesn't take too long before they're going to go into alcohol withdrawal or drug withdrawal. So if, say, they're addicted to oxys, and we're not giving enough oxys compared to what they're taking, they may have some withdrawal symptoms. For alcohol withdrawal, you'll see restlessness, insomnia, irritability. They're really irritable, and they may have auditory and visual hallucinations. There's scales that we follow to give medication, so you notify the physician and they order a protocol, and then we can give oral drugs based on how many symptoms they're having. Sometimes they even have to go to ICU and get IV sedation because it can be so extreme. And You may also see anxiety, depression. If you have a leg cut off because of infection, you're going to be depressed, so you may see that in the unit. So how do we manage the neuro and psych problems that we may see? We're going to assess their level of consciousness, their neural status, and their respiratory status to make sure that it's not lack of oxygen that's causing any of these problems. We're going to maintain a safe environment, the side rails up, the bed down. If the patient's delayed in waking up, we may be able to reverse the opioids and the benzodiazepines. If they're not waking up and say the physician wants to talk to them, or they're not breathing deep enough, we may be able to give them drugs to reverse it. On the clinical unit, we're going to assess, of course, and we're going to manage those fluid and electrolytes. We're going to try to get them to sleep. We're going to try to control the pain and assess the GI and GU status, and we're going to reorient as necessary, and we'll assess and treat alcohol withdrawal and also any drug withdrawal. The nursing management of post-op pain, we need to assess verbal or other indications of pain. So they may be really diaphoretic or really restless. A child wouldn't be able to tell you they're in pain, but you can tell when someone's in pain if they're guarding something, guarding a limb, or grimacing. We're going to treat with analgesics, IV opioids, PCAs, and the PCA can be IV, can be transdermal, and it can be epidural. A non-opioid can be infused in a surgical site, such as bupivacaine, and that numbs up the area, so it can reduce the need for opioids for up to 72 hours. It works quite well. Kids really should have regularly scheduled meds rather than PRN, because they may not be able to recognize until they're in a lot of pain that they have pain, so it works better if we can control it. So there are alterations in temperature that we need to be aware of. A hypothermia is where the core temperature is below 96.8 Fahrenheit. The elderly and women, those with systolic blood pressures under 140 systolic, are at higher risk for hypothermia. And it can be because of heat loss, because they're exposing a large amount of your skin to this really cold OR. It can increase pain. So if you're cold, your pain automatically increases. It can increase bleeding, and it can decrease our immune function. Hyperthermia can occur from an infection, wound infection, pneumonia, urinary tract infection, a clot in your leg, and sepsis, which usually, of course, sepsis is from an infection in one of those areas. Nursing management is the assessment again. We're going to do a temperature immediately post-op, and then every 4 hours, and then if the patient's complaining of any symptoms, we want to check it more often. If they're cold, we can passively warm them with warm blankets, or we can do like a bear hugger. It's it kind of reminds me this old-fashioned hair dryer that you put it on the patient, and it's hooked up to a machine that actually pumps in warm air around the patient. That's for hypothermia. To prevent infection, we're going to encourage the patient to turn, cough, deep breathe, and use their incentive spirometer. And because definitely the atelectasis can lead to pneumonia, and that causes fever. We're going to notify the doctor if the patient has a fever, and we're going to do usually blood cultures and a urine culture, and possibly antibiotics will be ordered. The GI problems we might see are definitely nausea and vomiting, and it's common from the drugs that are given in the OR. And of course, GI surgeries contribute to that nausea and vomiting. You might see post-op ileus, where the bowel doesn't move. It's temporary, but it can occur post-abdominal surgery. It causes a lot of pain, abdominal distension, and gas. And it can be from the patient not moving after bowel surgery. They have to get up and move. And in spite of no actual evidence-based practice that shows that it's important to move, it seems to be, that's the practice, is that we get the patients to move. And if they don't move, they can get a post-op ileus. And that extends the days of hospitalization, and it causes a lot of pain. So the patient needs to get up and move. Hiccups can be from irritation of the phrenic nerve. And it can be from that gastric distension. It can be from an obstruction. It can be from an abscess. Your book didn't mention this, but a new pacemaker that's put in, a pacemaker lead can move and it can stimulate that phrenic nerve. So if a patient has a new pacemaker and they have more than 30 minutes of hiccups, it could be because of that pacemaker stimulating that phrenic nerve. So you would need to call the physician. Usually hiccups are pretty temporary, but if they last more than 30 minutes, there's a problem. It can be from acid base and electrolyte imbalance. The nursing management is, again, you're going to assess. You're going to give oral fluids only as tolerated and as ordered. So if the patient's NPO, they're NPO. You're going to medicate with antiemetics, and you're going to give IV fluids. We're going to, again, encourage early ambulation, encourage them to pass that gas, not to be embarrassed about it. And if they lay on their right side, that helps the gas move up to get released. Urinary problems. Low urine output is expected for 24 hours, and that's I had spoken about in a previous slide. But urinary retention can occur from anesthesia, from opioids. It can be from those anticholinergic drugs that are given in the OR. And it can be from lower abdominal or pelvic surgery, and it can be from pain. You don't want to move, so you don't want to pee. Oliguria may occur from renal failure, which is a definite problem. So we want to assess. The urinary output should be at least 0.5 mils per kilogram per hour. Remember that. You want to remove any urine catheters within 24 hours or less. I think the actual protocol at Health First is that it needs to be removed within 48 hours. If they don't have a catheter and they're not able to void, we want a bladder scan before we try, before we put in a catheter. We want to make sure they actually have urine in their bladder, and we want to try non-invasive techniques such as putting the water on, pouring warm water over their peri area, anything that you want to try first before you actually cath them. Men often need to stand up to urinate because when they're laying down, the prostate gland may be enlarged and they may be unable to void. Skin problems. Wound infections can occur from flora in the environment, or it can be our own skin, and that's why they disinfect. It can be oral or intestinal flora. So the people that are malnourished, the older patients, immunocompromised patients, so maybe someone going through chemotherapy, if they've been in the hospital a long time, they've been exposed to a lot of bacteria, and long surgeries put those patients at much higher risk for wound infections. The symptoms are redness, swelling, pain, tenderness. So normally an incision, it might be red on the incision itself, but around the incision is not. It should be a normal skin color. Maybe slightly swollen, but it shouldn't be really, really swollen and really, really tender. They should not have a fever, and their white blood cells shouldn't be going through the roof if they don't have an infection. So those are the signs. It's usually not till the 3rd to 5th post-op day, though. Nursing management includes assessment again. I'm sure you're sick of that. Documentation. We're going to notify the physician if there's excess drainage or a change in the vital signs. The doctor usually does change the first dressing. So after surgery, we would reinforce if it's draining a lot, but the physician actually changes the first dressing. After that, it depends on the physician's orders about whether we're changing that dressing. Discharge from PACU. So in the hospital, the PACU gives a verbal report to that receiving nurse. It still might be over the phone, it might be face-to-face. For the patient going home from the PACU, so the outpatient area, the client must be mobile, they must be alert, they must be stable, so the vital signs have to be controlled, and their pain and their nausea and vomiting must be controlled. It is pretty amazing how those seem to be a little bit loose these days, because after my colonoscopy, I felt like I was not alert, but out the door they send me, grab onto me, put me in the car, and send me on my way. Discharge teaching is done with a caregiver and the client. It includes how to take care of the wound, when to resume activities. So like for a heart cath, some doctors say they can't resume normal activities for 5 to 7 days, or if they can shower, what they can eat, when they can eat, when they can resume their normal medications, when to call the doctor, when to follow up. So that's all those things are very important. And we need to teach back, use teach back techniques. So when I give discharge teaching, I'll say, okay, tell me what did I say, when could you shower? And sometimes the patient says, oh, I don't remember, or they guess, but that's because they're so anxious to go home, or they're still a little bit under the anesthesia. So it is important to make sure that they understand those instructions and that they are bringing home written instructions as well. The client should not drive, whether it's moderate sedation or regular general anesthesia. They should not drive, and they should have someone stay with them for at least 24 hours. It's very helpful to have a follow-up phone call within 48 to 72 hours. It's helpful for the family and the client to review any of those discharge instructions and to answer any questions, because they often forget to ask the questions when they get home. They're like, oh, I don't remember about what I'm supposed to do about this. So it's very helpful to have that follow-up phone call. Not most surgical centers do that. I have to say that our cath lab is not very good about doing it in a timely manner. We might do it in a week, which is a little bit too long in my opinion. So let's review our key assessments and interventions. Let's go back. Assessments for respiratory. We need to assess the O2 sat, teach, encourage them to cough and deep breathe. The cardiovascular problems may be from hypotension or hypertension, from fluid overload or retention. We need to monitor the fluid, the intake and output. We need to implement VTE prophylaxis. In other words, wear the stockings if that's prescribed, or the plexi-pulse boots if that's prescribed. Give heparin if that's prescribed. Get patients up slowly. Treat the hypotension with fluids and oxygen. Treat hypertensive tension with antihypertensive meds. We need to monitor for alcohol withdrawal, assess their level of consciousness, manage the fluid and electrolyte status, manage their pain. It can be done with analgesics, IV opioids, PCAs. We need to monitor their temperature, call a physician if their if their temperature is elevated. medicate for nausea. I also find that ginger ale does really work, but make sure that the ginger ale has real ginger in it, because ginger ale has some of it doesn't actually have ginger in it. Ginger is the drug that actually helps with nausea. We need to monitor their urine output. Make sure that they're having at least 0.5 mils per kilogram per hour. Try any non-invasive techniques prior to having to catheterize the patient, even though you as students are desperate to do that urinary cath. We need to monitor their wounds, make sure they don't have an infection, reinforce it, or change the dressing as ordered. For discharge teaching, we need to use teach back. And the effects of surgery on the pediatric patient. I guess I did do it in the second video. So I did do that in the second video, and that's the end of this video. I thank you very much.